It's probably time now to start kicking off this evening's webinar. So as for those that are used to all of this, if you could mute all your microphones, it makes the quality of the sound a lot better so that you don't get any feedback. And if you're struggling with the feed, maybe turn off video as well, and it improves things a lot, as well as people not seeing if you're up to anything you shouldn't be, as they say. The video can be dangerous in that regard. So tonight is interesting. We're going to, I suppose, continue the theme that we've started there last week, looking at how we return to surgical services around the country following the pandemic and I suppose the expected surge that was there. Lots of things have stopped, no elective surgery, lots of things up in the air, and yet there's a massive unmet need. And we heard last week of the growing waiting lists in surgery in particular, and we have to start making plans in the midst of COVID-19 as being a real and ever-present risk for the foreseeable future anyway, and how we need to rethink the way we organize our lists, organize patients, the prioritization of those, and examine all the various factors that are involved. And tonight we're taking the whole kind of understanding of the whole team and the whole perioperative approach, and we're joined by colleagues around the country who are going to give us that, I guess, overview and wider perspective that everybody needs to take into account as we sort of make plans for reactivating surgical services around the country. So tonight, as always, we'll be opening up with a regular update from our president, Mr. Ken Mealy. But then we'll get down to the business of looking at the whole organisation of our operative activity, and we're grateful for the involvement of colleagues from Limerick, University Hospital Limerick, Miss Michelle Cooke, who's a clinical nurse manager 3 in the ASAU, and Mr. Declan McNamara, who's the Director of Nursing in the Peri-Operative Directorate in UHL as well. And they're going to talk to us about those nursing and organisational perspectives around the theatres. And then we're going to get an insight from one of our hospital managers, Miss Mary Garvey, who's a general manager in Roscommon University Hospital, and who's going to talk about the perspective that the hospital management have to deal with in planning the recovery of services in their hospitals and all the various dynamics and challenges that are there, because I think we have to put multiple variables in our heads as we try and reactivate things. And then we'll get down to a Q&A session. Just to remind everybody, we use the chat function on Microsoft Teams to send in queries or comments. I'll take those at the end of the session and put them to the panel, and hopefully we'll get a good, vibrant discussion going at that. And we'll take it from there. So I suppose to kick off, we're going to invite our president, Mr. Ken Mealy, to give us an overview on the various national committees and discussions that he's been involved in representing the college and surgery in those areas. So Ken, over to you.
Kieran, thank you very much, and good evening everyone. You're all very welcome. This is our 6th webinar, and we're really pleased to have so many of you join us on a weekly basis. As always, we're really interested in hearing what you have to say. We want to get feedback from your comments, not only in particular in relation to issues that you may have, but also to give us ideas for future webinars so that we can share best practice from around the country. As Kieran has alluded to, the initial meetings really looked at crisis management, and with a huge emphasis on both patient and staff safety, particularly in regard to PPE and some of the logistics around that. But we've moved on over the last number of weeks. And again, as Kieran has said, last week we started to talk about protocols and care pathways for patients, now that we're starting to consider how do we get back to normal. Now, we all understand that the new normal will not be the same as the old normal, and there's a lot of challenges in bringing patient care in a scheduled sense back to any sort of routine. And we really need to work very closely with our colleagues, not just our medical colleagues, but also our nursing and administrative colleagues. So I'm really delighted tonight to welcome Michelle Cooke and Declan McNamara and Mary Garvey, because it's clear to all of us that surgical planning and process management cannot take place without us working very closely with our administrative and nursing manager colleagues. So I look forward tonight to what the other speakers have to say, and I look forward to the comments and questions. And I thank all of our speakers in advance for their input. So I'll hand back to you, Kieran.
Okay, thanks a million, Ken. Well, our first speaker up tonight then is Miss Michelle Cooke, who, as I said, is the clinical nurse manager in the ASAU in UHL, and she's going to give us the ASAU perspective on reactivating surgical services in the system. So, Michelle, without any further delay, I'll hand over to you, and we'll be taking questions at the end of the panel. So, off you go.
Thanks very much, Kieran. And I'd like to thank you for giving us the opportunity here at University Hospital Limerick to speak about the Acute Surgical Assessment Unit. I have slides there as well, so we might just start with the opening slide, please. Can you see the slides?
Oh, perfect.
Great, so you can go on to the next slide there. So I suppose the Acute Surgical Assessment Unit here at University Hospital Limerick has been guided by the National Clinical Programme in recent years in terms of the national standards and the guidelines for monitoring and progressing an acute surgical assessment unit, and we're delighted to be on the accreditation earlier this year. So the principles for the acute surgical assessment unit remain the same. You just go on to the next slide, please. So the principles in any situation is delivering senior decision making early in the pathway of the patient journey, and the decision to admit to a ward, discharge or theatre remain the same throughout this crisis. Next slide, please. And in terms of quality care, it's patient-centred care that we deliver through our acute surgical assessment unit in line with the key performance indicators as guided by the National Clinical Programme Guideline. And next slide, please. So in capturing the process when COVID-19 came into play in the beginning of March, the process remained relatively the same, but in terms of a data capture, we had to put this on hold. So this was another challenge to us in terms of how we manage the data piece in terms of an acute surgical assessment unit. Next slide, please. So in line with the HSE National Emergency Situation, the University of Limerick Hospital Group had to identify specific pathways for COVID and non-COVID patients through our emergency department. And through the CEO and the crisis management team here with the Peri-Operative Directorate support, we were requested to establish a surgical ED to assist with the pathways of the COVID and non-COVID patients. Next slide, please. So as we developed this flow chart in terms of to distinguish how we manage the surgical patients through our emergency department, and in terms of surgical presentations, what the old prior to COVID was, we saw general surgical patients. With this new surgical ED in the COVID crisis, we had to expand our criteria to include all acute surgical presentations that remained between a category 2 to 5 status. And with this flow chart, the category 2 was a big change in the sense that we had to have strict criteria around category 2, and it is from consultant in the emergency department to the registrar in the acute surgical assessment unit. That is how the patients are presenting and how the transfer of care and the governance piece is monitored. Next slide, please. So overnight, the ASAU was from the 25th of March, I suppose, went to 24/7 unit. Prior to it, we had 8 bays. It went from 8 bays to 16 bays through the expansion of our pre-op assessment area. So all our scheduled surgeries were put on hold and we went into unscheduled care. And the agreed pathway that was developed through the Peri-Operative Directorate in line with the crisis management team and through the CEO was that they were all Manchester triage in ED as normal and were identified for surgical specialty review. They would be transferred to the surgical ED. And the pathway up to the surgical ED was for non-COVID, non-respiratory patients. And this was really important to identify the COVID and the non-COVID patients on arrival to our triage department. The triage nurses and the emergency doctors in ED have identified a COVID checklist, and through this process, we were able to safely manage the patients that came through our departments. It's currently now is resourced with a registrar 24/7, and each specialty registrar is available for referrals within a maximum of 1 hour, ideally to ensure patients are expedited as speedily as possible for discharge or admission. So these were to all the subspecialties. Next slide, please. So with change, we have many models for improvement, and we use many of these action plans. The Plan, Do, Study Act, we had to sit around many tables to decide to create and initiate and understand the new processes that faced us in this COVID-19 crisis. Next slide, please. So the big piece around it was the governance structure, and we developed a standard operating procedure in line with our crisis management team and our CEO, and we developed a SOP around all surgical specialties, which included urology, gynae, orthopedic, maxillofacial, ENT and urology, and general surgical. We had to go from our nursing whole-time equivalent, we had to go to 24/7 basis. We had a lot of work around upskilling our staff nurses and redeploying staff into the area from other areas. From our scheduled activity was stepped down, we were able to redeploy nurses from our surgical short stay unit up to our surgical assessment unit. Our WT increased up to a maximum of 21 WT, and that included CNMs and healthcare assistants as well. Prior to the COVID-19, we would have had GP access, but that all GP access and referrals are now sent through ED. We still have our bed bureau system, which is our booking system, which allowed us to book the staff, or book the patients in through a system where we have a log system. So they're discharged from ED and they're transferred up to the surgical assessment unit. We were fortunate to have our advanced nurse practitioner in prostate care was working from the unit as well and was redeployed into the unit, which was a great asset to have an advanced nursing role within the ASAU. And also our auxiliary service, including portering, catering, diagnostics and clerical support is now there 24/7 as well. The biggest asset to it was the diagnostic access piece, which was previously problematic when we were Monday to Friday. Next slide, please. So with the COVID-19 crisis, the challenges that we were faced with was the social distancing, and the area that we currently work out of as an acute surgical assessment unit was 8 bays, it went up to 16. We displaced our POA, or Perioperative Assessment and Day of Surgery Admission area. So this is now relocated to another area. The social distancing is quite challenging in keeping in line with the national guidance on social distancing, and this is something that we are continuously working on to try and improve. Our location as well in the area that our waiting area would be challenging in terms of structure. I suppose our data challenges, we did have a fabulous data system which was capturing our patient's journey in line with the KPIs. So we now had to step that back, and we are using the IPIMS and bed bureau system that we have here. The sustainability piece going forward, to maintain a 24/7 service. This is I suppose an uphill and a downhill battle. It's interchangeable on a daily basis, and the nursing manpower, I suppose, monitoring staff in terms of sick leave and in terms of sustainability to try and manage that piece has been challenging. Next slide, please. So I suppose this is just hot off the press in terms of preliminary data that we pulled from our bed bureau system, and I suppose you can see there for the month of April, this data just shows our attendances from daytime only, from 8 o'clock in the morning till 8 p.m. at night. We've seen a total of 719 patients, and we've seen up on 28% of these are up on orthopedic patients, and there's a breakdown of different presentations there. Urology as well is up, and ENT. Next slide, please. This just gives you a breakdown of the time of day that we were able to look at in terms of 2 hourly intervals in terms of our attendances. You can see the most attendances were from 12 until 4, where we saw approximately about greater than 50% of our patients are in between those hours. We are looking at data that we are currently collating for night time as well, which would be interesting to see in terms of the figures for night time. And next slide, please. And it's just a snapshot of the orthopedic presentations, as this was a new subspecialty that we took on. There was a lot of training involved in terms of upskilling nurses from an orthopedic perspective as well as other subspecialties, but particularly orthopedics. And you can just see there from that data that our highest presentations are between 12 and 4, which was interesting to see. Next slide, please. So I suppose our new normal, as Ken mentioned there earlier, is to have the right patient in the right place at the right time, seen by the right senior decision maker early in the pathway. So COVID-19 has put us into a crisis mode. Has this been for the better? I think it has, personally, but it definitely gets the patient on the pathway early in their journey and seen by a senior decision maker. The data would suggest that it does reduce the PET times, that this is something that we're working on. We can see the turnaround quicker, we have access to diagnostics early in the pathway, and patients are seen by the senior decision maker early in the pathway. Our A&P role is very optimistic there in the unit, and there is I see future avenues for an A&P role within the ASAU as the senior decision maker. It has increased patient satisfaction. I would say it has looked at patients are seen and they are treated quicker, and they are access to diagnostics and turnaround time. It does have organisational benefits in terms of patient satisfaction and staff satisfaction, and as I said, the A&P role is definitely something that we would value for the future. And next slide, please. So on that note, a bright future beckons. The onus is on us through hard work, honesty and integrity to reach for the stars. And I do believe that despite COVID-19, it definitely has some positives. Thank you.
Michelle, thanks a million for that presentation. That's been superb, and it's really such a positive message to see how people have been innovative, they've adapted, they're meeting the new reality, and they're being really successful. And I think it's always heartening to hear the stories from the various hospitals, because I think, you know, to hear the level of activity that's going on through the ASAU is extraordinary, and the way the staff have adapted, the specialties have adapted, that's extraordinary, and we'll come back to that at the end of the session. So that's been great. Thank you very much. And I guess, you know, well, moving on from the ASAU, they come in the door, then where do they go, I guess? And we got to get them down to the theatre, some of them anyway. And Declan, you're going to give us a perspective on the whole Peri-Operative Directorate and what's going on there, and the things that you have to try and consider in getting surgical services back. So looking forward to hearing what you have to say, Declan.
Okay, Kieran, and I hope I answered some of those questions. Kieran, thank you very much, and to Jamie Logan as well for the invite on tonight's webinar. I really appreciate that. Thank you very much. I suppose I'll just start with my first slide there, please. I was going to say Colette, but I think it's Erica, is it? Great, so you can move on to the next slide there. Yeah, I suppose just a little bit of background of the UHL Hospital Group. We serve up to a population of over 400,000. We have 4 Model 2 hospitals. That's Ennis, St. John's, Croom and Nina. We don't have a Model 3 hospital, which is quite significant for the size of the population, but also the Model UHL Model 4 hospital has a bed capacity of 452 beds, and it's about 36% of those allocated to Peri-Op. Now, I deliberately left in the vision and mission of the Peri-Op Directorate, because that remains unchanged. As Michelle has said, there's been over 719 patients come through in the last month through our surgical ED that still require care. So we continue to deliver patient-centred excellence in the Peri-Op Directorate, and we continue to strive for a safe, streamlined, efficient and effective care within the Directorate. Our strategic directions have changed slightly, which I'll touch on in a few minutes, and our enabling strategies remain unchanged. Next slide, please. This is in our heyday when we unveiled the Nina cataract service, and these are photographs we want, I would imagine, as part of change we will not see again, where Simon Harris is surrounded by a group of wonderful nurses who made the cataract service happen. But significant is the dash on the right hand side there. Within the Peri-Op Directorate, we have 471 nursing staff, medical and dental 165, management 86, general support 32, a real team effort up to 833 staff that work within the Peri-Op Directorate. Next slide, please. This is just a fundamental piece that is close to myself in the fact that the key values of nursing, compassion, care and commitment is unwavered and doesn't change no matter what we enter. We are within the COVID pandemic and this remains to change. So this is underpinning the professional values of nursing and midwifery. It's just a key point to make that does not change. Next slide, please. I've referenced just Ernest Shackleton here. Ernest Kildareman, and one of his first boats was Discovery, and I suppose that's what we're on. We're on a new discovery path with COVID, and it's changed how we think and how we actually deliver services. How did Shackleton prepare himself? I suppose he hired an outstanding crew. You've just heard from a wonderful lady who works closely with me in Michelle Cooke. I have a wonderful aide on Alan O'Gorman as well, but it's a team, and this is a team piece that works towards the dealing with the COVID crisis. I suppose we report into a very senior management team that meet on a daily basis, and that's led by Kenneth Cowan and is supported by Noreen Spillane, Jerry Burke, our CCD, and Margaret Gleeson, our Chief Dom. That goes towards an effective crisis management team to support us and the delivery of a Peri-Op service. But the other things that Shackleton laid out on was creating a spirit of camaraderie. And I think COVID has done that. It really has cemented nursing and all health professionals, because we've one target, we've one enemy, and we've really joined together to try and to fight that. So that's really has really created a very strong spirit. It's definitely getting the best from each individual, leading effectively in a crisis with our crisis management team. And to be honest, there was tough assignments being handed out, and our team have stood up to that and have delivered on that. Michelle has just mentioned there about the surgical ED. We had to put a whole different team in there to support it, to increase the WTE, to make that happen, to make it a 24/7 service. And that required training on frontline services, supported by our medical colleagues. And that went out without any problem at all, and it worked really, really well. And in fact, as Michelle has indicated, it proved a very efficient model. So we overcame the obstacles to reach a goal, and I suppose it will be our legacy. Next slide there, please. What did we leave behind? I suppose up until February, these were the specialties that were being delivered within the UHL hospital group, all the way from colorectal. I've identified the ones that when we came into March that we just maintained, and that was our trauma and orthopedic and emergency service. Everything else was basically stood down unless it became an emergency. Just on to the next slide, please. This is the Peri-Op Directorate has two pathways. The two pathways is unscheduled care and scheduled care. So this was pre-COVID, and then the red would indicate what stopped as a result of COVID. So as Michelle has said, the surgical ED is taking over the ASAU. Our emergency department continued, emergency theatre continued. Our ICU and HDU increased capacity went from 10 to 12, and then we added additional potential 16 beds. Our outpatients departments were stood down only, and our POA, which is pre-operative assessment and day of surgery admission, only started. So POA recommenced last week on the 27th, and that's in preparation for what I will talk about in a few minutes. What we started on Tuesday, the 5th of May, was our day of surgery admission to start back in theatre. POCU was our post-operative care unit. That was where our high critical surgery would spend 24 to 72 hours recovering. That also closed down because obviously we weren't doing the high-grade surgery. Our surgical day ward is no longer, and cohorting is stepped down now because we have predominantly medical patients in our surgical beds. Next slide, please. So all this reduction in activity, what did it mean? It meant that all the Model 2s that I've mentioned redeployed all their theatre endoscopy staff into the Model 4 to support the potential surge that we were due to expect around our ICU and HDU. So that was approximately 30 members of staff from these hospitals that came in, and basically, I suppose it's something to mention about our theatre staff. Our theatre staff would not normally put in wouldn't do venipuncture cannulation because it's all done for them by the anaesthetist team. So this is just a simple skill that all our team had to upskill on, was venipuncture cannulation, and even such things as use escalation. So the national early warning systems. So these are now nurses working in our units, on our wards, supporting the additional capacity that we've opened in order to cater for additional COVID patients. So they've all upskilled from duties that we would normally routinely do to such things as I've given you an example of venipuncture cannulation, escalation processes and things like that. We redeployed from our outpatients department as well. So because in effect, our outpatients department closed. We had a surgical short stay unit as well. And because the surgery wasn't going through, we redeployed them. Now we redeployed them to our surgical ED because they were best placed to provide surgical expertise to our surgical ED, and they've blended in very, very well. We also redeployed advanced nurse practitioners, assistant directors of nursing, and our CNSs. So like COVID knows no boundaries, we redeployed all staff, and that's significant, has never ever occurred before. And Michelle gave a really good example of one of our redeployed ANPs went to our surgical ED and is a prostate ANP, is now supporting patients that are urology issues, like doing trial without catheters, doing issues like that. So that's a real positive bonus and a compliment on the ANPs. Our assistant directors of nursing were redeployed to skill base that they had previously, working in dialysis, working in other areas. Fundamentally, from a nursing perspective, I reference the values. Our scope of practice is something that you work towards, like all healthcare professionals. And we just added to that scope. We identified their training requirements and got them upskilled in a very, very short period of time. So that was a key piece, was training and education had to continue. And then we had to identify the social distancing. So where we would normally run an IV study day, we had 20 plus students in the room. We were reduced now to 10. So that became a piece that we had to work around. So we ended up running telecoms and things like that. Orientation of staff, our clinical skills facilitators and our nursing practice development units were first class in supporting the redeployment of staff, training and education, and basically a hand on shoulder, pardon the pun, but from a social distance, in supporting these staff in being redeployed. Some of the key things that we developed and worked on is a thing called an iHub, which is, I imagine it's a national piece, but also it's just a go-to centre for on our local IT unit, what would I say, package, basically, that all information regarding to COVID information is available on our iHub, like the on-call facilities and things like that. So that's the one go-to place. If you need to know something about a new COVID pathway, whether it be for POA or for theatre or for ICU or HDU, you would find it available on the iHub, as also the changes and movement regarding PPE, donning and doffing and things like that. We developed a staff app as well, because with so much communication coming through, we managed to secure a staff app that we shared key nuggets of information in relation to COVID updates and things like that. And that's proven very, very effective. To date, we've over 2,500 people signed up to the app. And if we were doing that any other time, we wouldn't have received that. We also set up a nursing manpower unit, and that was to try and streamline all the rosters that were currently going on in so many different departments. So we could go to one place and see exactly what the staffing was in certain particular areas. That's work in progress, but it is as a result of the COVID pandemic. And as a done, I've just given you an example there where so many areas in the Peri-Operative have closed down. As a result of that, I've now assumed responsibility for medical wards as well, just to try and share out and give support to my other Don colleagues. Next slide, please. I suppose, so one of the key things as a Director of Nursing and sharing it with Alan O'Gorman, the Assistant Director of Nursing, and Michelle, one of our CNM3s, is that the fundamental thing that we need to maintain was good communication and sharing support with our nursing colleagues. And I suppose one of the things was we continued, first and foremost, BD rounding. So the nurse management team saw the wards, the ward managers, the team twice a day, that's morning and afternoon. We completed a 12 o'clock teleconference each day, and that's where all the CNM2s would dial in and just share their experience of the day. Key things being discussed is potential discharges, any issues or risks that are being identified, and any concerns, any work concerns regarding PPE, as in stock and things like that.
View on all the various challenges that you guys have had to face and organise and plan. I think it's really, interesting that we kind of get into the detail a little bit and actually look at all the various factors that are involved. And there's a number of good questions coming in on the chat function. I remind people to have a look at that. And so keep those coming in. We'll put those questions to you guys at the end of the session. And so the last speaker then we have lined up tonight is to bring the hospital manager's perspective on all those things. And Declan, you mentioned at the end of your your presentation there, the issue of budgets and where that's all gone at the moment. I guess there's a perception at the moment that like we got to do whatever we got to do, but of course when we have to start looking at the realities of all the services and different patient groups we have to deal with and treat later, there's no doubt the issue of the budgets are going to be a major issue for us all. But so I guess to getting our heads around planning all of that. The workforce issue, of course, is another major problem to figure out. So it'd be very interesting to see how Mary Garvey, our General Manager in Roscommon, is going to sort all that out down in the West. All right, Mary, over to you. You're muted there, Mary. Mary, you're muted there, so.
Sorry, can you hear me now, Kieran?
Yeah, have you now?
Yep. Thanks very much, Kieran, for inviting me. Maybe budgets isn't a great place to start on when my background is I'm an accountant by trade. So, but budget has been kind of far from my mind the past few weeks. But we probably need to get ourselves focused back into it again, or it'll be focused for us. I suppose for the past few weeks, as a hospital manager, my focus has been primarily on, medical patients, getting ready for the potential surge of medical patients with COVID. And I suppose surgery probably took a back seat, to say the least, for a while. I mean, we were just kind of focusing really on our cancer services, which in our case would be endoscopy, melanomas, and the hematuria service, just really trying to see what we could do for those. But really, our focus was medical patients and the surge that we were expecting. So needless to say, we didn't thankfully get the big surge that we were expecting, particularly in the West anyhow. And I suppose things seem to have stabilised a little bit, and we're now turning our focus to getting our surgical services back up and running again. One of the surgeons here said to me yesterday, actually, that the biggest mistake that we could now make is kind of trying to get things the way they were. And she's right. So, like, while it is true we do need to address our problems and our challenges and get our services back up and running, we have many challenges from an operational perspective. We really need to look at the opportunities that this presents to us now to do things in a different way, particularly maybe in surgery, and that maybe to work a bit more smarter and a bit more efficiently. For example, one of the things we've learned in the past few weeks is that virtual clinics do work really well. And we really should have been making more use of telemedicine before this. But I suppose there wasn't that pressure to do that, and it is hard sometimes to change our ways, but I think anybody who wasn't a fan of telemedicine before has been converted, and they really have worked really successfully. So, but of course, telemedicine is one thing, and it is great to be able to give that service, but we will always have to bring patients in. So the challenge for us now is how do we do that in an outpatient setting where patients have to be brought in, and in a, for surgery as well. So I suppose I speak from the perspective of a smaller hospital. For those of you, most of you will be aware, Roscommon's part of the Celtic group, and we're a Model 2 hospital within the Celtic group, and I suppose different to our previous speakers from University Hospital Group, the Celtic group is different in that it only has one Model 2 hospital, well, at Merlin Park as well, which is part of the Galway University Hospital Group, is a Model 2, but we have lots of Model 3 hospitals in the Celtic group and one Model 4, but we're the Model 2 of the group. So we don't have any surgery or trauma surgery to worry about, but what we have really is the non-complex day surgery, ambulatory care and diagnostics. And I suppose just in terms of specialties, we'd have general surgery, vascular, plastic surgery, endoscopy, maxillofacial, urology, dental, and then from an outpatient perspective, then we have ENT and orthopedics as well. We just do those from an outpatient perspective. So, we were busy developing our services, very, very busy in the last few years, really building our services and building on our specialties. So this has, we're facing a new challenge now compared to what we were. I suppose the biggest challenge I think that is facing any hospital, not just us, but is any hospital, is the infrastructure. Now, in our case, for Roscommon Hospital, we are designated intermediate care facility for COVID. So what that means is the plan was that we would provide up to 80 medical beds for COVID and non-COVID patients. If things were really bad, we were going to provide up to 70 medical beds for COVID patients and hold over a few for non-COVID. But the idea was possibly it would be 40 COVID, 40 non-COVID medical beds. In order to achieve that, we had to move over our medical services into our surgical areas. And I suppose just given the size of the hospital, and this probably would common to a lot of hospitals around the country, just the way the size of the hospital and the configuration, our only option really was to initially we converted our surgical day ward. We also had a plan, if needs be, to convert our endoscopy unit. Thankfully it didn't come to that, but we have converted over our surgical day ward as the designated COVID ward in the hospital. So that has essentially shut down our operating theatres. That wasn't a problem a few weeks ago because we weren't looking to do any surgery a couple of weeks ago. But now that we look to restart our surgery, now we have to kind of look at the options that we have and see how could we regain our surgical ward and move our maybe reconfigure our medical wards into areas where we would have an area for a suspected and confirmed COVID cases. I mean, I suppose that is our new reality going forward. This isn't a short-term thing, but a long-term thing. But I mean, irrespective of that, even if we were to regain our surgical area, our surgical day ward, we are going to lose capacity because I suppose we're not going to be able to facilitate surgery. We cannot achieve social distancing for patients in the ward in its current format. There's 15 day beds in our surgical day ward, which is adjacent to our theatres, and I don't think for a minute that we could just go back to the way we were. So what we would need is a bit of investment, but we would be, I suppose, join the queue for all the rest of the hospitals in the country. Now we do have other areas within the hospital that could be looked at as well. But again, we would need investment, but I guess everybody's going to be operating off the same way. I think what we would have to do as well is we would have to look at maybe extending our working day. We're not going to be able to bring in the same volume of patients or anywhere near it in our traditional 8 to 6 working days. So we may need to have to look at extending our working day or extending our working days and look at doing elective surgery across a 7-day rota. Again, I suppose we're going to reconfigure our spaces. Another thing is, apart from funding, we also need planning permission, and planning permission doesn't come overnight. So any kind of building project you embark on or refurbishment program you embark on in the HSC tends to take a lot of time. So I suppose we probably need to look at improving our processes in terms of how we achieve that. I mean, we did a very rapid reconfiguration of the surgical ward in order to have it so that we would have isolated rooms for COVID patients. It was really practically done overnight. And if only we could apply that to all our other projects, it would be one benefit. I suppose some of the things are that we want to minimise the risk of surgical patients bringing in COVID, but obviously we also want to minimise the risk of them contracting COVID in the hospital and taking it out with them. So I suppose at the moment we have endoscopy operating 2 days a week this week, where we've done urgent cases, and we've been able to do that because we were able to assess the risk for endoscopy unit, and we're very lucky we have a new purpose-built endoscopy unit which opened in 2016. It has its own separate entrance, so we were really able to manage the flow of patients. It's got a one-way flow for patients anyhow, and we were able to manage the flow of patients so that literally the patients could come in on a staggered basis, wouldn't meet anybody else in the hospital, come straight into the endoscopy unit, have their scopes and be discharged. And we did the phone triage the night before and all that, and made sure we had adequate stocks of PPE. So we were able to manage that quite successfully. So the trick would be but that is because we have really good infrastructure for our endoscopy unit. So the challenge would be trying to recreate that across the hospital. I suppose I know there are guidelines being developed for surgical patients for various specialties and how that will work. We weight those, but I suppose some of the things that have been talked about are asking patients to self-isolate for 2 weeks, maybe prior to surgery, which would seem reasonable, but then I suppose, is it reasonable to us, but is it reasonable for the person who's expected to self-isolate? Would they be able to achieve it? Can we guarantee that patients will comply with that? We could look at maybe patient testing. I know now there is rapid testing in some of the hospitals where you can turn around test results in 4 hours for COVID. That's not available in every hospital. We are looking at achieving that here in Roscommon. But that would involve some investment in equipment. But I certainly think it would be very useful if you could have that rapid testing on site on the morning of surgery. It would certainly help to give some sort of reassurance to staff and patients. The single biggest challenge, I suppose, for us at the moment is PPE, and I think that is across the country. I mean, it's no secret that there is a massive shortage of gowns out there. The previous week we were worrying about masks, and I think the week before that we were worrying about visors and goggles. So it's kind of like you get one supply line sorted and suddenly there's a shortage for another supply line. If you are scheduling surgery, and that actually has been a consideration, which is really, I suppose, shameful to say that one of the considerations that we had when we were considering would we restart the endoscopy unit was could we provide PPE, and were we trading off PPE that would be used in the endoscopy unit against PPE that we might potentially need on the wards. So that is an ongoing issue. So I suppose we would need to be reassured in relation to the supply lines. I suppose another challenge is the staffing. Now, the previous speakers were talking about how staff were from the Perioperative Directorate were redeployed to other into the medical wards and into from the Model 2 into the Model 4. So what we've had was all our surgical staff were redeployed into the medical areas, and there was the upskilling and all that. So at the moment we would be short on staff. If we were trying to maintain all the medical beds we have at the moment on a 7/7 basis, we would struggle to reopen our surgical services as well in terms of staffing. One of the big problems would be, especially in a smaller hospital, would be segregation of staffing. So particularly for support staff, like we would have to have reassurance that if we would have maybe catering staff, cleaning staff, allied health professionals, healthcare assistants, and even nurses and doctors, that if we had somebody working in surgical area, that we wouldn't be, they wouldn't be trying to pull them to supplement medical staffing. You'd want to have complete segregation of staffing, and that is something we would have to be able to stand over, and that brings its own challenges. I suppose one thing that we maybe could be considered would be pooling between hospitals, between smaller hospitals. So rather than each hospital being self-reliant for its own staffing, that you would pool your surgical staff between the hospitals and you would pool your medical staff between adjacent hospitals, and rather than pulling between specialties or between directorates, that you would pull from within directorates between hospitals, and that is something that would need to be looked at. I suppose we do need to examine the new ways of working. So we spoke about the virtual clinics, and we're looking now at using the Attend Anytime software, which is being rolled out, and we've done some demos, and we're going to try and roll that out now across the hospital. That would be for outpatient clinics. I mean, up to now in plastic surgery, which is a specialty here in the hospital, which has really grown over a number of years. Photo triage is something we've been kind of dabbling with and talking about for a long time. So the last few weeks, we've really focused in on that, and that is something that we really need to develop now properly and invest some money in photo triage. And that would certainly cut down on unnecessary maybe patient attendances, and being able to triage the really urgent patients without actually having to bring them in the hospital. That's an area. Outreach clinics is another thing that we previously looked at doing, again under the specialty of plastic surgery, but it could be rolled out for other things. So we looked previously, actually applied for funding under Sláinte Care to do outreach plastic surgery clinics in some of the primary care centres up the northwest. So at present there is no plastic surgery service in the northwest, and the plastic surgery patients from the northwest come to Roscommon and to Galway for their appointments. And we looked at potentially running outreach clinics using our A&Ps in some of the primary care centres up around the northwest, and that's something that maybe could be revisited. I think something that has really maybe taken off a bit and could be learned from this, and something which wasn't maybe traditionally looked at, was working from home, particularly for administrative staff. So we have a lot of we have space requirement. We have constant challenge in relation to space requirements, particularly as we expand our services. And sometimes we're looking at we have administrative staff in areas where probably might be better used for clinic staff, but it was like where we put the administrative staff, if we move them, we couldn't magic space out of the air, and some of those administrative staff are now quite successfully working from home. And I think just for work-life balance, for facilitating people, for attracting people who maybe are living away from home, particularly in a county like Roscommon, where people might like to move home, but there aren't jobs for them. And down Limerick and Cork, that people who work in those hospitals live elsewhere could also work from home, and that might tick a few boxes in terms of space and in terms of facilitating people's lifestyles. The other thing is the electronic patient record, which is long talked about and being trialled on a smaller basis, on a limited basis in University Hospital Galway. That is something I think that we really do need to expedite as well, the investment in the electronic patient record, and give it a push on. And the last area we're looking at, well, something we have been looking at before this, was robotic process automation, which is something the Office of the Chief Information Officer is looking at, and the Digital Transformation Office is looking at rolling out, and then that in terms of just kind of increasing our efficiencies for administration, we could look at robotic process automation, and that might help with some remote working as well, and some expediting of triaging and that. So that's kind of it for me. I don't have an inspiring quote to finish on, but I suppose I will just say I think this brings a lot of opportunities. There's a lot of challenges, and I think about it a lot, I'll probably end up getting freaked out. But I think if we just kind of chip away at it, and I think we need to solve our infrastructure problems first and foremost, and decide what areas we're going to use, and have a kind of a plan, and then try and, because if we don't tackle the waiting list, all the non-urgent stuff or non-life-threatening, non-time-sensitive stuff that we've been kind of, I don't like to use the word ignoring, but we've pushed to the side and we haven't prioritised in the last 2 months. We're going to have an insurmountable problem if we don't start addressing it as soon as possible. And that's me.
Great, Mary, thanks a million. Yeah, you've a lot going on there, all right, that's for sure. And I think that's if I have anything from this evening, I think we've heard from all our speakers, just the range of variables and challenges and areas and issues and things you have to consider. And you're trying to look ahead, but the current demands are challenging, that's for sure. And what seems like a plan now will have to change in a matter of weeks, depending on how the whole COVID thing works out. So we've been getting lots of good questions and queries coming in on the chat function, and indeed many sent in a few questions before the session, which is always helpful to get our head around a few things. But I might just start off with a question come in from a colleague, and it's from two colleagues really on a similar enough theme, and it's in the area of I suppose testing. So we hear a lot from around the world about testing is the key to all of this, if we can get it going. So there's one aspect is the approaches that are being taken in your hospitals around the testing of staff, and how regular that should be done and how well that should be maintained. And then there was the mention of I think Mary, you mentioned the rapid on the day of surgery testing, and Declan was talking about the protocol there where essentially patients are cocooning or minding themselves for 2 weeks, but then you might have to test them on the day of admission, because obviously in that 2-week period, while it might seem fine, things can change for the patient. So you test after 2 weeks, and then you test again. So what, Mary, maybe you always say, what's the approach in Roscommon around testing at the moment, both between staff and patients? Again, Mary, you're muted there, so you might unmute. Yeah.
Okay, so I suppose we have on-site staff testing here, which we didn't have weeks, and caused us massive problems in terms of staffing, because if we had somebody who was out as a suspected with symptoms of COVID, we waited in some cases up to 2 weeks for testing in the community, and we didn't have on-site testing for staffing, but we got around that problem. We now do have on-site testing for staffing with a turnaround, kind of a next day turnaround. Now, as it happens, the community testing figures our wait times have really reduced as well, so that isn't as much of a problem as it was, but it's really only where patients are, where staff are showing symptoms for testing. I mean, and if you were going to do there was talk about doing widespread testing, and I know there are some places, like for example, the community nursing units have done widespread testing, but that's a point prevalence testing, and just because I'm COVID free today doesn't make me COVID free tomorrow. So unless you're going to me every single day I come into work, it's not really of any benefit. And I mean, that would just totally overwhelm the system. Again, in terms of patient testing, so I know some of the hospitals in the SAIL group have what's called a piece of equipment called a Gene Expert, but really it's not for large volumes of testing. It's only for maybe where you really need a rapid test results for patients. That was the idea of it. Now, that's not to say it couldn't be rolled out further. We would like it to be rolled out further, but it does help with patients because it does allow you to make very quick decision making in terms of where you're going to accommodate patients. I think in terms of what we would need to achieve in surgical numbers right across the HSE, I don't know if that's a runner at the moment, but there may be probably further investigation. It certainly would be useful.
And Declan, in Limerick, what's the approaches there at the moment?
Yeah, just around two things is around the staff testing. I just got a piece here is that the molecular testing for COVID-19 in UHL can generate results within a matter of hours. So that's going on here, but it can only complete up to about 10 tests per day for UHL. There's also PCR testing, which is 200 local lab tests can be done on a daily basis. But in relation to what I referenced in the handover, in the presentation around pre-op assessment patients, they would go to their GP, and their GP would request a swab, and the swab would be our local swabbing centre, which is St Gabriel's, which is quite close to the hospital, and they would be given an appointment time to turn up there. So what I've said as well, Kieran, is that would be done 3 to 4 days prior to their admission date. So that would be the process here. Just about staff, it is only swabbing symptomatic staff. We haven't done any other screening or anything like that.
Okay, that's great. And our President Ken, you wanted to say something on this as well? Thanks.
Yeah, I think we need to really be careful about the issues in relation to PCR testing. The original reports from China indicated there was a 20 to 30% false negative rate with PCR testing. And some of the reports coming out of the States suggest that it's up to 15%. So one of the reasons we test is, yes, so that you can stream patients into COVID, non-COVID pathways. But if you consider that there's a 15% or greater error rate, you really need to bear that in mind. An important reason why you might test patients is so that you can risk assess them if they're going for major surgery. And this is going to be increasingly important as we get back to some sort of normality where we are scheduling patients for major surgery, particularly thoracic procedures. So if you test them and are positive, you would defer surgery. But I would just caution everybody in terms of testing being a panacea for giving you absolute proof that your staff are safe or your patients are safe. That is not going to be the case. And we're going to have to live with this uncertainty for months and perhaps years to come, where we can never be absolutely certain that a patient has not got COVID, irrespective of the tests.
Okay, so that's really good perspectives there on what's going on in testing, and I hope that was helpful to the people listening tonight. Another interesting one, and Michelle, you mentioned the impressive numbers of people that you dealt with in the month of April. I was just curious, of the 719 that came into the ASAU, how many go on then to actually have a procedure? Is there what sort of percentages, maybe a ballpark?
I suppose the data is preliminary, Kieran, in the early stage. So I suppose the admission rate is quite low. It's looking at the numbers preliminary. Our average admission rate by day is anywhere between 3 to 10 patients, whereas the turnover, the discharge rate is quite high. So I suppose the access to diagnostics is the big piece, and I suppose that streamlines the patient journey, and it gives us answers early in the pathway, whereas before patients would have needed admission for that piece in terms of diagnostic access. But it's early stages, I suppose, in the data piece to answer that question. But it's looking positive. Great.
Because isn't that going to be the next big issue, is that when getting our theatre capacity to meet the demand as more and more, I guess, more of the public start presenting at the hospitals and are coming with their conditions that either couldn't wait any longer or just getting more confident that they can actually present. I think a lot of us are thinking of the other surge that's out there is all the other conditions that haven't been coming to our hospitals in the last few weeks. I think another area that was very interesting that you mentioned, Michelle, was the role of our ANPs and how important they have been to actually, adapting to the whole new way we do things. And a couple of questions have come in around the role that the ANPs could play, perhaps in telemedicine or in the virtual clinics. What's your thoughts on that?
So I suppose the ANP has been invaluable really in the surgical assessment unit, and we were lucky to have the ANP for prostate, and we also have our ANP for tissue viability service working out there as well. So it has proven it's effective in the sense that they're the senior decision maker, and they can decision to admit or discharge lies with the ANPs. There's a huge role for them to play within the unit going forward. Maybe it's an unscheduled care ANP within the unit, and it's something that we would be looking forward to, in the sense that the patients can be seen, treated in a timely fashion if we have more ANPs working out of the unit, in terms of specialties as well. We've seen by the tissue viability service, they've seen, for our urology, it was a big hit as well within the unit because we didn't see urology patients before COVID, and now we have a huge, I suppose, benefit of urology patients coming to the department as well. So urology A&P will be valuable as well going forward.
Just a point there as well, Kieran. Our A&P in orthopaedics, Audrey Butler, currently runs virtual clinics with a large cohort of patients. For example, metatarsal, metacarpal fractures. She sees those predominantly virtually and gives appropriate advice there. I suppose the telemedicine piece will open up surveillance, pre-procedure discussions, discussion around treatment options, post-procedure and follow-up procedures. As Michelle has said, our TVNs carry out big procedures on VAC therapy that can be managed in the community. And sometimes they just need a follow-up call and a friendly face to say, listen, how are you doing? And that would work really, really well from there. So, but absolutely, that there really is a piece there that those A&Ps could manage that cohort of patients quite independently under the clinical support, professional accountability piece with the DON and with the consultant for that area. It would work very, very well. No problem at all, I'd say.
Yeah, Declan, I think that's good, because one comment came in here was like, you know, what's the story about indemnity? Is this within the scope of practice and so on? But I guess, you know, you always answer there, if we have good protocols, they're signed off by people, and there's good, you know, good governance, I guess, of the whole process and so on, that should help deal with that. So there are ways of people rising to those solutions, but there's nothing that we need to consider maybe around the nursing and midwifery board around some of these roles either, do we? Or you think that's pretty much in hand?
Been very clear on it. Advanced nurse practitioners, to start to become an advanced nurse practitioner, you develop a clinical accountability with those consultants, be it vascular consultants, colorectal consultants, orthopedic consultants, whatever. They will all, that A&P will always be clinically accountable to those consultants and professionally accountable to the Director of Nursing and Peri-Op. So that's there, that's happening, and there's good evidence out there. I'm just giving you an example there of an advanced nurse practitioner in orthopedics that deals up to 14, 15 different caseloads between our LIUs and managing those. And it works really well. But what it does do, Kieran, it reduces your footfall into our clinics, and that will have to be the way forward in how to reduce those footfalls, is telemedicine and more A&Ps in these areas. We keep mentioning our A&P in prostate. Sheila Kiley is an advanced nurse practitioner in prostate. She was dealing with prostate up to 6 to 8 weeks ago. She's now dealing with urology issues in the absence of a CNS or an A&P in urology. And like that, she's dealing with them because she's got the clinical knowledge, but she's also got the clinical support from the urology consultant leads, and I'm supporting her from a professional accountability point of view. So that's covered, so that doesn't need to go anywhere else. And it just shows real efficiency, to be honest, and effective use of skills. So that can be mirrored in any discipline in surgery.
That really, I mean, I think you've given the way the solutions, and people can rise to those solutions. And I know our own Jamie Logan, who works in the national clinical programs in the college, does a lot of work in this area. And I guess, you know, it's an ongoing message to get out to everybody that there's these innovative ways of dealing with it. So well done. Another area that's kind of interesting is the staffing level challenges. And Mary, and Declan, I guess this is going to be one of the things that are really going to be on everyone's minds right now. We've mentioned a few times that some of the solutions might be extended days, extended weeks. You know, we're going to be slower. Most of our surgical colleagues are saying that operations are going to be slower, a lot more PPE, the operations will take a lot more time. Therefore, to get to any reasonable level of workload that to meet demand, we're going to have to consider longer days. And it's just having the staffing levels, I guess, and also then you have a lot of staff that are having to, you know, be our contacts, and therefore can't be ready for duty because they got to go off and isolate for a while. So we have probably increased. You know, we probably worked all the bases. I know myself, we would have always worked on the basis around sort of 10% or 12% or so of the staff are off, either due to sick leave, maternity, holidays, you know, all that sort of thing at any one time. Now we've got this added COVID thing and isolation going on, and they're being redeployed. So could you maybe explain? I know you mentioned that there was a nursing workforce unit there, Declan, in Limerick, and Mary, you're probably considering all these things. Maybe, Mary, you might tell us how you're going about that at the minute. Again, muted there, Mary. So, yeah. No, still muted, Mary. Just press and give it a second.
I have no.
Perfect.
I have no patience, Kieran, that's my problem. So I think, well, really it's kind of day to day almost in rejigging rosters. Now, I suppose we were very conscious when we restarted our endoscopy that we would 100% not have anybody who was working endoscopy anywhere near the medical wards. But I suppose because we've started up in such a limited way, that's been okay. And it's been achievable, but you just have to plan in advance and cross your fingers that you don't get too much sick leave. We've been pretty good the last few weeks, fingers crossed it continues, that we haven't had too many. We've been pretty unaffected really by COVID leave, and because of the staff, like now even when people have symptoms, they're back relatively quickly because they get their testing done rapidly, test results are back, and once they are 5 days afebrile, they can come back to work. So that has helped a lot. One challenge, and I suppose it probably just needs to be addressed at national level, but is we have lost a number of staff who are falling to the high risk categories, immunocompromised and long term there has to be a plan for those staff. I mean, they can't all be off indefinitely, and it is having an impact on certain services. So that is something that would need to be, but I would be interested to hear about the workforce planning that's been done down at University Hospital Limerick.
Yeah, thanks. Can you hear me? Are you okay there, Kieran? Can you hear me?
Yeah, yes, Declan, yeah, far ahead.
Back on, I suppose, and I come through workforce planning unit, I suppose the one thing we have done just to try and work through the current pandemic, which we really haven't hit a very, very high surge, is annual leave has been reduced. It has been reduced to a management and manageable level at each ward level. And I suppose the other thing is that there's a couple of initiatives that came nationally as well around, obviously the students now, our second and third year students, they're all be given HCA contracts, and that's about 40 of those coming into service supporting who can do observations, who can escalate care, who can do pieces like that. So that's a fairly strong workforce coming in to support our frontline services. I suppose the other thing I mentioned in the handover or the presentation was career breaks. We've had about 5-6 staff that have now cancelled their career breaks. That's only until the flights are back up and running, you know what I mean? So that's a short-term, it's great, but fundamentally going forward, there's two things I would love nationally to look at, and that the first one would be around student intakes. We have a designated amount of students that we bring into our universities, and like the number for UL will say is 55. That those days need to be looked at, because at the end of the day, we need to be looking at bringing 60 to 70 students in to our universities and training them up for nurses, because there's a constant shortage, and there will be a shortage. COVID will come and is here to stay, but we do need to start building our student workforce up to a 70 plus that are graduating. Now, of those, you're going to have an attrition rate. So you're probably talking of those 70, you probably have about 61, 62 that will qualify. That would be a one way of dealing with the nursing shortage going forward. It won't be immediate, but what it will be is that in 3 and 4 years' time, we'll start reaping the benefit. For when these students hit the wards at the end of year 3, we will have them then as part of our numbers. The other thing, and I was in Roscommon there at your wonderful hospital, had a guided tour through your endoscopy suite at the launch of the urology model. And I suppose there's two things from that, and that is what you call it. There are now roles in hospitals that do not need to be delivered by nursing. And I'll give you an example. In the UK, they've got ODAs and ODPs who assist inside in the operating theatre. That would free up valuable nursing resources to do other things and develop as AMPs. So that is something seriously we need to take to hand, because ODAs and ODPs will be there to assist the setting up of the patient for surgery, would also be there to set up to support the anaesthetist in preparing the patient for an anaesthetic. So they have a real big role to play and would free up our nursing staff. The other thing, there's a large majority of our nursing staff dedicated to CSSD, and that is processing equipment from a quality perspective, and that's another piece that we do need to look at. So I would say there's a couple of things we could be looking at from a nursing national perspective. First and foremost, increasing our nursing cohort of students coming into our universities, and secondly, looking at what tasks can be not completed by nursing. I give an example there of ODAs and ODPs. That is they're in every English hospital. They're in some of the private hospitals here as well, and it's something that we do seriously need to look at. And it's referenced inside the urology model of care. I suppose just on that, on the urology model of care that was launched in Roscommon there was little reference to AMPs and Ps. There was reference to it, but it wasn't a funded model. So that's another piece, I suppose. If we had funded models of care coming from the clinical care programs, it would allow the building up of our AMPs and CNSs to these senior positions and would retain our staff. And that's the other piece, is if we have promising posts like AMPs and CNSs, you would then retain staff that are going abroad or going travelling, because then they would see their career here. So there are a couple of things there. The nursing manpower unit is solely around, for the first time ever, we are going to have one site that will look at the staffing of the entire hospital at one database, and we'll be able to move staff between units. For example, if on our trauma ward we've got 7 nurses on duty, and in our surgical wards we've got 3, we could redeploy there. So that's what that model will do. It's a little bit pre-trend care. Trend care is a model of towards safer staffing. This is a piece that will do the electronic piece of that, and will identify on a day-to-day basis what your staffing level is on a ward, and it will be able to do it up to for the whole week for you. So it is a movement towards that. But the other thing they're supported to do is recruit and retain as well. So that's a piece around what I've just mentioned there.
Great, Declan, thanks a million. And I might just bring in, we're going to come to a close now in a minute, but I might just ask our President Ken to just come back in, and maybe Ken, what sort of discussions are going on at the department level on the workforce issue? Because it is going to be one of the biggest challenges all the services are going to face, I think, in the next couple of months.
Kieran, I think nationally there's various groups looking at this, both within the senior leaders meeting with the Department of Health, which occurs weekly, and also the COVID-19 strategy group with the HSE. And we're only really starting to talk about the need for additional staff. It's been alluded to tonight that the new normal is going to be much less efficient. The care pathways will be different. We will need more time, maybe with an extended working day, to get through anything like the work that we would have previously done. So we really need to think about how we use our staff, and those suggestions of looking at ODAs and other grades, I think, are really important. I think various nursing grades, as you've already heard from Limerick, acting up, taking senior management roles is really going to be the way forward. Is that going to be possible? I don't know. I take the point that you've made, that at any one time, maybe 10 or 15% of your staff may be not available because of self-isolation or being ill or whatever. We're only working through those things now. But I was impressed tonight with the 3 presentations, because it strikes me that unless we start sharing the innovations that you are carrying out with other hospitals, we'll never get back to any sort of normality. And for every hospital and hospital group to be working within a silo mentality, working these things out for themselves. And yes, in some ways we do need to work things out for ourselves, because each hospital has issues in relation to themselves which are different to other hospitals. But so much of this is sharing best practice. And I really was impressed with the lengths that all of you have gone to think through the different processes. So all I can do is commend each of you and say, yes, at a national level, we are working at many of these issues. I can't pretend we have solutions as yet, but I do believe that we will get clarity in the coming weeks as to how we do go forward in terms of returning to some form of elective activity. And the future webinars that we will hold here on a weekly basis will hopefully address some of these issues as we get more information, and look to your colleagues around the country to share what they have learned in the intervening period. So look, well done. I don't have all the answers, but yes, certainly at a national level, this college and others, the other professional bodies are exactly the same, will be working on your behalf, not only to improve patient welfare, but also to protect and support colleagues who are doing really wonderful work around the country. So thanks all of you for taking part, and I'll hand back to you, Kieran. Thank you.
Thanks, Ken. Well, all it brings me to say now is just to thank all of our speakers, so Mary, Declan, Michelle, and our president for taking your time in particular, and putting together a very thoughtful presentation and giving us a huge comprehensive understanding of all the variables that we have to try and consider. I think it's great to be able to broadcast those to our surgical colleagues around the country, and thanks to everybody who tuned in tonight. Because I think all those ideas are going to get everybody thinking, talking, understanding of the areas they need to deal with. We'll be sharing the slides on the website, and they've already been, I think, pushed out on this chat function, which will be available for the next 24 hours. But all our presentations are up on the website. They'll be recording all the various talks as well for people to look back and use. Please feel free to use them for any education or training sessions you want to use in your own hospital. And on that, I just want to wish everybody a very good night. Stay safe, and we'll see you all next week. Thank you very much. Good night.
Thanks, Kieran.